We're so pleased to have with us again Dr. Volker Gerdts. He is the CEO of VIDO InterVac at the University of Saskatchewan, one of the companies in the world, or the organization's research facilities, that is moving toward a vaccine against COVID. And you're making some great progress. Very soon you'll be into what you guys call toxicology studies, which I guess means you got to figure out whether it kills anybody or not before it works or not.
That's right. Thanks for having me. So the tox studies are really designed to address any unwanted effects to the vaccine. So you're injecting it into animals and then you study the tissues and you see if there's anything going on that shouldn't, and that will then inform you about the safety of the vaccine.
Let's just step back for a moment and just, I've got to ask this question because we keep talking about the second wave. Is it here, or is this just the first wave and we're heading into fall and people are going back to school and spending more time indoors, so it's just a bump in wave one, or is it second wave?
So I think it really depends on where you're talking. So, the second wave in my mind is because people are not as diligent anymore in their public health measures and what they do, wearing masks and limiting contact and so on. And that is because the schools are now reopening, right? People are there is a little bit more normalcy right now. And so we will see a higher caseload with people coming closer together and not following the rules. And so that might be earlier in Toronto or Ottawa or Vancouver than compared to Saskatoon or even rural Saskatoon, where it may take a long time, or maybe there is never a second wave.
That's what I think people are trying to sort out. I mean, is it obviously in Saskatchewan you can think of some reasons why we're dispersed. We're only 1 million people.
That's right.
So we're never going to have the numbers of a Toronto or a Vancouver in any circumstance. But are there behavioral differences? Is there something else to explain it?
So I think from in the beginning we thought that might be the virus that changes and we will see a second wave because the virus has found a new way of evading the immune system or something, but that's not the case. Right now I think the higher caseload we're seeing around the world is that everywhere kids are going back to school, that there's more activities, whether it's rallies in the US or other activities.
And they're partying.
And so on. And so those activities are contributing to the spread and even to the super spreaders. And so then you have a few individuals that are positive and not staying at home, and they could at those parties then potentially infect 30, 40, 50 people. And then you have these little centers flaring up, and so that's then how this can become a bigger problem.
It's inevitable that we're going to, and I think we're all feeling it, the COVID fatigue. Like, how long? And first you told us not to wear masks, then you told us we must wear masks. I think there was a poll done in the US that said a quarter of the population just doesn't believe anything that the health officials say, which then leads to, or in their own mind justifies, that behavior.
Right, and that's a huge problem for us right now, and I think Canada has actually done very well in terms of communication. We were trying to, or the public health officials were trying to be as clear as possible from the beginning. But the situation changes. In the beginning, the advice was for the public not to wear masks because we thought we needed them in the hospitals, right? And so now that there is sufficient supply for the hospitals, we don't see as many ICU patients as we had anticipated. Well, then that means others can wear a mask too. So then, of course, you recommend to wear a mask. So, it's hard in the beginning of a pandemic, which is so big and nobody really can foresee how it's going to unfold, to always give the right advice and stick to it. You have to adjust, and as the situation unfolds. And I think that's what we're seeing, and in most countries, not all.
It's raising that question for me because we're all watching what's happening with President Trump and his interview with Bob Woodward, and when did he know, what did he know, and when did he know it, all of those things. Issue is the same here. And almost in every other country, it seemed like we weren't paying attention, and we'd let all our readiness in the post-SARS world kind of slip. And therefore, we didn't have any PPE, and we didn't know what we thought about masks and all of that. How do you keep that tension up so that we are ready?
I think the difference what we have now compared to what we have seen before is that SARS-1, MERS, Zika, influenza, most of them didn't have the global impact that this one has. So, in people's mind, maybe after a few years, the MERS or Zika issue, that wasn't really a big deal. And so this urgency is maybe not there, which then, when other priorities are there and, money is not available, then you might shift some money away from paying an insurance fee for the pandemic preparedness.
Like having PPE available.
For example, PPE or manufacturing capacity or research facilities that can do the type of work, all of those things together. I wouldn't say the country was unprepared, but I think we could have been better prepared.
You've mentioned manufacturing, which is one of those things. I mean, there's lots of groups around the world, we'll talk about that in a minute, working on this vaccine. But once we find one that works, or several that works, then you have to make it in the tens of millions to have it effective.
Even.
Do we have that capability?
So Canada doesn't. Of those 7 that are going forward at the moment, let's just assume 3 or 4 will make it,
right,
and will start mass production. And they all are already manufacturing. They're waiting just for the green light to then ramp it up and even start distributing it and so on. Those all had to be supported right now. They were all supported by the Gates Foundation, by the WHO, by international agencies and so on, to build up that capacity so that we can quickly do it. And even with all of that being ramped up right now, it's still going to take a year or maybe even 2 years before we are in the situation that we have immunized all the people that needed to be immunized.
You've said as a scientist, and I know you have to kind of separate this out from the bragging rights that you have for doing such an amazing job here in Canada, but that you think that the vaccine you're working on is in some senses superior to others, that it'll succeed in the long run, where others we may find flaws in it. Why do you say that?
So the type of vaccine, the technology that we are using is what is called a subunit vaccine. And so that is a proven technology that has been in humans before for other vaccines. So, hepatitis, for example, or pertussis, tetanus, those are all subunit vaccines. So we know they work and they are easy to manufacture. So you can make many million doses very quickly. They're very cost effective. And most importantly, they're safe. They have a really, really good safety profile. And so if we compare them to the others, so the RNA, so the Moderna vaccine or the German BioNTech vaccine, the Pfizer one, those are new technologies that have never been in humans. And although scientifically they all make a lot of sense, we actually don't know how well they work in humans. And then those adenovirus vaccines, so the Oxford vaccine,
right,
the AstraZeneca, and then also the Johnson & Johnson vaccine, those are based on another virus, a harmless virus carrying that gene of the COVID virus. And so that's a technology that has been experimentally tested already in a number of clinical trials.
Okay, what does that mean? You're injecting a new virus, but not a deadly one.
Right. So for that one, we're using what is called a viral vector. So you're using a common cold virus, an adenovirus, which doesn't cause disease by itself, and you genetically engineer it so that in addition to its own genetic code, it also has a piece of this COVID-19 vaccine. And so when the virus goes in and does, infect cells and replicate and so on, it doesn't cause disease in people. And it makes the immune system believe that the SARS and the COVID-19 virus is there. And so then we're making an immune response to this genetic information, to this protein that is encoded by that gene that we engineered into it. So it's a really elegant technology. It's really good. It has been tested experimentally for malaria, for TB, for HIV, and so on. And in the future, we will see more of those vaccines going forward. But as of now,
right,
there is currently no adeno-based vaccine in humans.
So go with the tried and true, which is what you're proposing, which is you want to trigger the immune system to fight it to let the body fight it itself.
That's right. We're using a part of the COVID-19 virus, but we're not using another virus. We're not using RNA. We're using a proven technology. We're showing it to the immune system, and by adding what is called an adjuvant, so it's an immune modulator, a stimulator of the immune system, we're saying to the immune system, hey, here, this is what you need to make a vaccine, or an immune response against. This is what you need to make an immune response against. And then we have an effective vaccine.
So you're in this toxicology phase, the kind of the first one, which is find out that it's not lethal right off the bat. And then you start to move into testing, which you're going to do very quickly. Finding people at this point to become the human guinea pigs and say, okay, ready, is that going to be difficult? And what are the risks, like genuinely, for people who want to stand up and say, okay, I'm going to do what I think is right for my country, not just for me? Is it going to be hard to find that?
No, I don't think so. And we have had lots of people contacting us, phoning me in the office, sending emails, all the way from Vancouver to Halifax, from coast to coast, really.
What motivates them?
They wanted to just, I think they're proud of the Canadian technology, a made in Canada vaccine going forward. They want to be part of it. And so what is involved in that? In the beginning, you go with a very, very low dose, and then you just watch for any unwanted reactions. And
in those phases of the testing.
That's right. And you slowly go up higher and higher. And so in the beginning, an unwanted reaction might be, does it hurt at the injection site? Do you develop pain in your arm? Do you develop slight fever, or are you tired, or things like that? Those are all being recorded, and based on the outcomes from that, we are then allowed to slightly increase the dose and so on. And so it's a step by step, and it's constantly be reviewed, just as the AstraZeneca is right now. And as soon as there is anything that stands out, a review board will review that and then assess whether there's any real issues or not.
I want to ask you about the AstraZeneca thing, because I guess nobody really knows, but they halted their trials because a person that was being tested fell ill. So that's good news. The system works.
Exactly.
And they were able to stop it. But it raised this question for me, which is, in the course, say you have 500 people or even 100 people that are being injected with the vaccine, and you're testing it. Just in the run of life, you're going to get a cold. You're going to, in extreme cases, maybe be diagnosed with a serious illness, a heart condition, cancer, or something. Then how do you sort that out as to what might have been triggered by the vaccine and what is just the natural course of someone's health state?
Right. So every trial has a review board, so experts that will review completely any information that is available there, and then make the conclusion whether it's vaccine related or not. And maybe it can, maybe the conclusion can't be made based on the evidence or the information that is available. But like you said, what this shows is that the process works. There's a rigorous review process. It's much easier for us right now going into phase 1, phase 2 trial, like you said, whether we maybe have 100 volunteers, while they're very closely monitored. These phase 3 trials now, they have over 10,000 people, right? So there you have people on the street that are part of it. They're all being closely monitored, but they live their normal lives. And so like you said, if they come in contact with a common cold or some other health problems, they will be flagged and then have to be individually reviewed to see if there is any correlation to the vaccine or not.
But it raises all these questions. So I'm in phase 2 or phase 3 trials, and you've given me the COVID vaccine, and I am riding on the subway or on an airplane, and I come in contact with a COVID positive person and end up with symptoms. Then how do you sort it out?
All in numbers game. So of the 20,000 people in the trial, or now, you probably saw in the news, some companies even want to increase it to 40,000 people. Right. So then you have, let's make it simple, 20,000 vaccinated and 20,000 that have not received the vaccine. And you compare the numbers, right? You say, in the face of normal life, exposure to COVID and so on, how many in the vaccinated group will get sick compared to your control group? You have to review in each individual case, but it's a numbers game, and hopefully the control group will be much higher than your vaccinated group, and that will show you that your vaccine works.
But it is possible that somebody that has been injected with the vaccine might still be infected if you're still uncertain as to its level of effectiveness.
Could be, yes.
And is there any fear that the other side could happen, that you have injected me with COVID as part of the vaccine, and therefore I become a carrier of some kind?
Not with these technologies. So they are, none of them uses a live virus. So all these vaccines are dead. So by injecting you with the vaccine, you're now not infectious to others. You cannot infect others. That's not possible. Okay,
well, that answers that, and I'm really relieved to hear that, because that's a discussion that's out there. There's so many other little things that are going on, and I want to ask you about testing and why while you're busy in your vaccine world, where are the people and who's doing the leading edge stuff on testing, so that we could get up every morning and before we go to work or walk into the office or the Senate or whatever it is, take a test and get a result then or in an hour? Like, are we anywhere close to that?
So there's a number of new technologies that are being developed right now that will significantly reducing the time. So some of them are under review, I believe, and soon might become available. So it's it's country by country right now, a decision on where they are with their tests, and politically how important it is for that administration to put resources into testing or not.
Because to me, this is a no-brainer. I mean, if we can test, then we can contact trace, and we can monitor literally on a daily basis, and people don't have to go home and isolate themselves for 2 weeks, because you'd be in a constant process. We can do it for baseball players and football players. Why can't we do it on a larger scale?
Right, and I think most people would agree with you. I mean, it's fantastic from my perspective to see that Saskatoon has now a drive-through, and Regina has a drive-through. So, to really bring that time down. Yeah. I think most people would agree. However, there is some people that say the more testing we do, the more cases we will find.
Correct.
And so,
like south of the border is what you might be referring to there. Yeah. Yes. Well, of course it's going to go up, but it's better to know than not know.
Yeah,
this is the other interesting testing, and I don't know whether this is going on here, but I think it is going on in Ontario, that people are actually testing wastewater or sewage as a way to trace where there are issues. Is that a feasible approach on a large-scale basis?
Yes, and I think it's actually a really, really good approach.
Wow.
So what it does is, it depends on really, really sensitive tests. So I mean, the sewage is really, if you think about it, is a way of pooling thousands of people into one tank, right?
Yeah.
And so if you now had a test that would be sensitive enough in that fluid to still detect the presence of the virus, you can predict.
You'd have really good detection.
The spread. You can't go and say, Volker Gerdts' household there is positive. You can't make that conclusion, but it gives you an idea of how quickly these diseases spread and how far they get within countries, and whether they're already in Toronto, whether they're in Edmonton now or in Calgary. So it's a pre-warning system. We can constantly monitor, and we can constantly say, okay, these are the pathogens that currently are circulating within the Canadian population. One question that a lot of people are bringing up with COVID-19, I'm sure you've heard this too, anecdotally, a lot of people are saying, I had this in December already, right? Before this virus was even found.
Did they?
We don't know, right? And most likely they didn't. But having a system like this would allow you to do exactly that.
There's another test that's out there, and I get people go through it all the time, is actually testing, your own gut contents, I guess. I can't put it any more elegantly than that. Would that be a good test?
So I think there then...
like a mini sewage system?
So I think the problem is that then somebody has to interpret that. Right? And so if we leave it up to people to now sample themselves, and then, as soon as you find something that shouldn't be there, freak out. There's finding something and something actually making you sick is still very, very different. And so these systems, the sewage control is really just a information system, an alert system letting us know what is circulating in our population.
And presumably it would allow us to target geography so that, Fishing Lake, Wadena, Saskatchewan is not subject to the same rules as Saskatoon, Saskatchewan, or Toronto, Ontario, or New York,
For example,
right?
could be, yeah.
And if you're using the sewage systems for that, which is, okay, you're good, we don't need to shut down your businesses, but you're not good, maybe we should.
Yeah.
Yeah. Okay, also I would love your thoughts on Denmark, Sweden, the people who have done the so-called herd immunity approach, or at least a much more, not closing down their systems totally, the Swedish example, looked good, then they had bad numbers, then it's come back to kind of reflect the numbers similar to those of us that engaged in the really extreme shutdowns. So, a couple of things. Is there such a thing as herd immunity?
Yes. So the short answer is yes. Herd immunity can differ. So we can have very, very good herd immunity for some diseases and maybe not so good for others. And so that all depends on how well the virus spreads. So if you have a virus that, if I was positive and I could now infect 50 other people, it is much more difficult to control than if I had a virus that potentially could infect 3. Right. And so the difference there is if we now wanted to control this for the 50, it's almost impossible. So essentially everybody would have to be vaccinated because the chance of me finding a non-vaccinated person is much bigger if I infect 50.
Right.
If it's only 3, we can have a lower level of herd immunity. We don't need to have everyone being positive. We can get away with 80% or 75% and so on. And so that number is identified for each pathogen. We know what the R naught is, and that's how it's called. We know how much it spreads. And so for this one, it was actually not as high as we initially thought, and so therefore herd immunity will play an important role in it. And I do think it can help in protecting it.
And we're now at that stage because we're seeing the number of deaths decline. People are being infected, but not with the dramatic numbers we saw at the beginning. Obviously, the most vulnerable.
Well, I think we're starting to see an effect of herd immunity, but again, we're so low. If you look at how many people really in the population have been infected so far,
like we're
the
1%
percentage
or
is so low, exactly, that you really on the big picture, that's not herd immunity. What you really need is 70% of the people infected, right, to really have, or 60 to have an effect. And so typically herd immunity starts to be effective in the range of 70 to 80 to 90%. For diseases like measles, you want something very, very high because the measles virus is very effective in even infecting people on the other end of this room. That's how contagious it is, right? So at 1% right now, we're not even at that level. But once vaccines come out, then we can be at that level.
Because then people will go out into the population, we'll socialize with each other, and people will be exposed to a milder form and then develop this? Like, how is that going to work with a vaccine?
Well, the vaccine will help. So the vaccine will give you the immunity that is part of, so you are becoming part of the vaccinated herd. So you are herd immunity. And so if we assume that we can get 70% people vaccinated, ideally, then you would have a protective level.
Okay, so that's different than the notion of herd immunity, which is if I'm semi-exposed out there in the public, like I am with a flu every year or whatever it is, do I build up a resistance to that?
And you become part of the herd.
Okay.
So I can induce herd immunity either by you surviving an infection and now being immune, or by me vaccinating you. And so Sweden and Denmark, or Sweden in particular, and then England in the beginning, as the vaccine was not available, they said, well, we let certain parts of the population get infected to raise herd immunity in that population. And Denmark now is, Denmark is just allowing kids at school to not wear masks and so on, but they still have very strict public health measures in washing hands, distancing, and all those things. They're just a little bit more flexible, I guess, on the rules in school. Sweden was the country where they let people socialize and took into calculation that the middle age group would get infected, would build up herd immunity, and therefore protect the most susceptible, the elderly, by essentially, having almost a wall around them, if you want, But as it turns out, the infection rate didn't even make it to the level where you had effective herd immunity. You never got 70% of all Swedish middle-aged people infected. And so you never reached that level where it actually made an impact.
So how do you define whether that's a success or a failure?
I think in looking back at the Swedish example, you can just show that it was epidemiologically an interesting way of looking at it, like the opposite of what most countries were doing. Has it worked? I think you really have to look at the data long term, 5 years out, whether there's any differences or not. I would predict that it didn't make a difference, and the reason for that is that they didn't get 70% of all Swedes infected.
So what are people supposed to think now? I mean, parents across the country are going crazy, not knowing whether to send their kids in. They're pulling them out if one teacher has, test positive. People don't know whether they should go to work. I mean, we're in a particularly kind of crazed post-Labor Day phase right now. What's your sense? I mean, should kids go to school? Should we go to work?
Yeah, so I got 3 kids, and they're all at school and at daycare. I'm as concerned as any other parent is, but I think the best is to follow the rules, to talk to the children, make them understand that it is important to wash their hands and wear a mask and so on. And for example, right now my kids are at home because one of them has a runny nose, and so just out of precaution, they're all staying at home. And so I think it's the best we can do at the moment. As soon as a vaccine is available, I would say everybody should get vaccinated.
But right now, get on with life while we wait for that.
But follow the rules.
Follow
and I think
the rules,
that's really that's the most important.
What are you thinking about your vaccine? Can you give us a timeline at all?
Well, so we're going into human clinical trials if everything goes well, and by the end of this year in December. And so then, sometime next year, hopefully summer or so, is when we would be in a position that we had vaccine doses available for targeted population. But it all depends on the regulators and how well it goes and how well the clinical trials go and whether the regulators approve it or not. So that would be our ideal scenario.
So when we hear about vaccines available by November 3rd, not that, that's just an arbitrary date we're pulling out of the sky there, is that even realistic? Anywhere. I don't mean just yours.
I don't think so. Yeah. But there is some, like those 5 that we talked about earlier, they are very advanced. And so I think by the end of the year, 2 or 3 of those might get the green light from the regulators to start giving their vaccine under an emergency authorization to populations that really need them. So frontline healthcare workers and so on.
I love talking to you. Thank you. You scare me, and then you reassure me, and then at the end, somehow, I feel okay. So thank you.
Thank you for having me.
And we'll talk again soon. Believe me, I'm not going to leave you alone.
Sounds good.
Dr. Volker Gerdts.